Hello, everyone. Can everyone hear me okay? CPT codes are sexy, right? Oh, come on, guys. I've got a lot of information that I want to go over. I wish Mr. Plaintiff Attorney was still here because I would have there was times I was like, wait a minute, whoa, wait, guys. I think he said some things that I personally, I would love to have a panel discussion or debate or something, because I do think that you do need to take a stand like on future medical costs. It's not okay for a doctor to say this surgery is going to cost $200,000. There still is a reasonable cost for that surgical procedure that maybe you do owe that for that surgical procedure, but it's not worth $200,000. There is a reasonable cost. So anyway, I call this the ABCs of medical billing and coding. You have a copy of the presentation, your binder. I'm going to go over some of it very quickly. Again, I'm available afterwards for questions and answers. I love to teach. I got into this business by having a ski accident. I was a nurse working trauma at the time, and I had a bad ski accident up on Mount Hood, up in Portland, Oregon. Now, I was working trauma at the time, and when you work trauma, you do a lot of physical lifting, right? Lifting and bending and everything. And I was staying still at the lift line. I was staying still at the lift line, and this bozo, my terminology, hit me from behind. His boot hit the calf of my leg, ruptured the artery, tore the calf muscle, cracked the fibula, popped me on my bindings, and I had a torn rotator cuff. I couldn't even use crutches. Now, I was injured. Ski patrol saw it happen, pulled the guy's season pass. It was very clear. I went through the whole thing, had an independent medical exam, all this stuff. I mean, it was just, anyway. Long story short, though, I was sitting there like, what do I do? What do I do? And I got a copy of my own hospital bill. Guess what? It had an error. And guess what? Those errors still occur. And guess whose favor they're usually in? I want you guys to know, I know that for so long, you guys have just taken the attitude, we've got it, especially for your own personal health care, you've taken the attitude, well, I've got health insurance, so the health carrier will take care of it. I think it's your personal responsibility, just like I think it's your personal responsibility to vote. I think it's your personal responsibility to start looking at your own medical records and bills and being an educated consumer. I think there was some medical dictionaries that were passed out, and I really encourage you to take that with you to your doctor. So when he's talking about something in the peritoneum or the Gray or trochanter, you can pull it out and say, wait a second. And then if you go on the back to like page 237, I think, there's actually anatomy and physiology. I've got some sign-in sheets, so if you if there's not enough dictionaries to go around, let me know, and or just put a star by your name. Tom, could you hand these out for me? I have a lot of handouts that I want to send to you, and so if you want them afterwards, let me know, or sign on the sign-in sheet. ABCs of medical billing and coding. This first slide, language of medical billing, is a slide that I will utilize when I am talking to a jury. I think Mr. Plaintiff Attorney talked about, if you want to talk about, how every sponge is used, blah, 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 blah. Well, this is what I utilize as my first slide for when I'm doing a jury trial. There are three components that make up the medical billing language. They are the CPT codes, which are professional procedures, HCPCS codes, which are supplies, ambulance, durable medical equipment, and IC9 codes, which are the diagnosis. Those are the ones that make up the language of medical billing. I want to come out and say, I am a nurse, and all I am doing when I look at these three items is I'm an auditor, for lack of a better word, for the American Medical Association. The American Medical Association is the one that makes up the rules, not the state of California, not Oregon Medical Association, not Dr. A, not Sequoia Insurance. The American Medical Association makes up the rules. And to me, it's very powerful at a jury trial if I'm telling the jury the doctor utilized a CPT code that was obsolete in 1997. Here are the CPT section numbers. You've got your evaluation management codes, anesthesia codes, surgery codes, radiology, etc. People will sometimes say, why do you spend time on anesthesia when the anesthesia bill can be $1,500 and the surgeon's fee is $15,000? You know, I've got to go for the gusto. I've got to go where there's the big dollars. Well, I beg to differ because we'll be doing my first criminal trial in Las Vegas probably in the next 2 months. I don't know how many of you heard about it, but about 3 years ago, it made national news where colonoscopy center, endoscopy center in Las Vegas was reusing colonoscopy tubes and endoscopy tubes and needles and syringes, and all these people were testing positive for Hep C. Yeah, really yucky. Anyway, a group of 3 doctors owned 5 clinics. They were doing colonoscopies and endoscopies to the tune of $100,000 per day, and they weren't even really doing them, but that's beside the point. But what my job was to look at the medical billing and coding. And what it turned out is each patient was being billed 1 unit extra of anesthesia per patient, per procedure, which is like $80. That's all. But yet they were having an influx of $100,000 per day. So I want to say it can sometimes be something really little, but you have to put it together. And I think that Mr. Defense Attorney, I don't know what his name is, but he was saying that you've got to put on the act. I think that it's really important, you know, what he said about having to have actors and actresses when you're at jury trial, to a point is true. But you've got to be able to educate. And I think that telling your expert, you know, you've got to talk to the people. You've got to let them understand. Because the Crane Pomerantz, who's the federal prosecutor for the state of Nevada, did not want to take this case. And the CDC, Center for Disease Control, FBI, everyone wanted him to take it. But he said, how am I going to explain CPT codes, anesthesia codes, time components, all of these different things to the lay public? And what was great is we got together for, I call a powwow, trials, you know, a war session, whatever you want to call it. We came up with a timeline. And what was really cool is Crane Pomerantz looked at that timeline and he goes, they can't bill for anesthesia if the patient's already in recovery room. So part of it is trying to get it so it's really simple for a jury. Here's some common CPT code modifiers. Sometimes you've got the 5-digit code for the CPT codes, but oftentimes I think what is abused by these is they're accidentally on purpose left off. HCPC stands for Healthcare Common Procedural Codes. How many of you are familiar with HCPC codes? Raise your hand. Okay, so you're looking at them. You've got a real good problem here, not good problem, I don't know, it depends on whose side you're on, but here in Sacramento with your ambulance billing. Next time you look at your ambulance bill, how many of you look at your ambulance bills really tight to see if it's advanced life support or basic life support? Anyone? Okay, start looking at that. You've got a great issues going here. We're working right now with the City of Dallas. City of Dallas is getting a refund of $6 million because the transport company, the ambulance company that they use for all of their transports were billed ALS for 4 years rather than BLS, basic life support. And I don't make up the rules. Again, there's very specific criteria that has to be met. Here's some sample HCPC codes. I'll sometimes have someone say, well, HCPC codes are not specific. So I beg to differ. Look at the third one, EO292, hospital bed, variable height, high-low, without side rails, with mattress. Now, even taking off my nurse hat, I can visualize that. You guys agree? Okay, ICD-9 codes, the International Classification of Disease. This was originated by the World Health Organization. I will sometimes get accused by opposing counsel that ICD-9 codes and CPT codes were set up for billing only. Bullpucky, no way, I'm sorry. This ICD-9 codes that are on those pink sheets that you get, those bills, those are spread throughout the world. So when you see that there's like 20,000 cases of malaria in Malaysia, it's because these ICD-9 codes are spread throughout the world. Soon they will be replaced by ICD-10. And the reason I go over ICD-10 is for two purposes. One, the Obama administration has mandated that it will go into effect by October 1st, 2014. You're going to be hearing a lot about it. You're going to be hearing a lot of resentment, reluctance from the treatment providers because it's costing them a lot of money, because they're at the same time also going to the electronic health record. Also, though, we are one of 3 countries in the United States or in the world that does not have, civilized countries, that does not already gone to ICD-10. So if you have a claimant here in the U.S. that's injured here in the U.S. and they go back to Germany or Sweden or Switzerland, those countries are utilizing ICD-10. And you can see that there's a lot more code, so it's going to be much more specific. Advantages are codes are more specific. It'll be much easier to cross-reference diagnosis and treatments. Disadvantages is we don't give the crooks enough credit. They are really smart, and they are going to take advantage. And I think more treatment, because of more codes available, it'll be very easy for treatment providers to list more codes to upcode. Okay, evaluation management codes. Everyone familiar with that? Yes? Who's not familiar? Okay. Am I going too fast? No. Okay. Evaluation management code is also known as an E&M code. And this is something that is an exam that's needed to develop some kind of course of treatment. So you're doing a plan. And the best example that I can give you is of your annual physical. Now, who feels comfortable with your E&M codes? Who in this room? I think you raise your hand.
I used to do medical billing, but for my own self, when I go to a physical, I just look at my EOB, okay, it's paid, and I don't even look.
Okay, but you're familiar with the E&M codes, right? Okay, so, and your name?
Beth.
Beth, okay. And Tom, you are? Oh, okay, someone else, come on. Who else is? No one? Okay, I guess Dr. Beth. Okay, Dr. Beth. Let's say that Dr. Beth is going to take care of me. She is a chiropractor here in Sacramento that I've been seeing for the last, I'm going to say 2 years for maintenance treatment. I'm in this horrific car accident out here in the parking lot. I have, I don't have it, but let's say I have a BMW out here for my rental car, and it's got $500 worth of damage to it. So I come see Dr. Beth, and because it's a horrific car accident, you have to do a complete physical, complete history, and a complete decision-making process. Can you bill me as a new patient? Pardon?
I don't know.
Okay.
Oh, but you need x-rays too.
Right, you need x-rays too, right. Okay, what does the rest of the room think? Can she bill me as a new patient?
I would
Okay.
say yes.
You'd say yes.
Why not?
Because she has my history.
Oh.
Okay, and that's some key thing. So let's go to this. This is for Fresno. I just did this presentation in Fresno. Look at the code, the 99201 to 99205, and 99211 to 99215. Now, I think all of you have those cheat sheets that Jamie was nice enough to pass around. Does everyone have that? Okay, you've got that. That's for Northern California. Does everyone have it? It's got across on the left-hand side, it's got your CPT codes, and across the top, it's got your different zip codes for Northern California. And this is for 2012. And if you sign up on the email sheet, I'll be emailing this to you because all I've printed out for you is 2012, but I'll also send you 2010, 2011, 2012. Do any of you in here in this room deal with Southern California as well? Okay, I'll send you Southern California as well if you sign in. What about Nevada? Okay, I'll just send those 3 states or 3 different ones. But look at, you've got the code, problem, history, examination, and decision-making complexity, time, and then the price. And I can't see this in front of me because it's over to the side, but look at why Dr. Beth is going to want to bill as a new patient as a 99203, which is what? How much is that? 167 versus a 99213 as an established patient of what amount? Do you see the difference? Okay, since no one else raised their hand, another area where there's a lot of issue that I see treatment providers overbilling. Let's say that Dr. Tom's in the same office as Dr. Beth, and Dr. Tom is a chiropractor as well. He's in the same office, but he's never seen me. Dr. Beth has gone to one of these classes. As a side note, all of you need to ask your doctors about practice management. That's an assignment that I'm giving all of you, is ask your own doctor about practice management. There are classes out there on how to get $6,000 to $10,000 more per auto accident or work comp accident. So anyway, let's say that Dr. Beth is gone to a couple of these classes. Her biller has as well, and so she's off on a 3-week Caribbean cruise. So Dr. Tom is a chiropractor in the same clinic. So I go see Dr. Tom because I'm in this horrific accident. Now, Dr. Tom has never seen me. He's a chiropractor. Can he bill me as a new patient? What do you guys think? No. Why? Got the history. Okay, good. Okay, let's say that I go to, what's your name? Joe. Joe, okay. I go see Dr. Joe. Dr. Joe is in the same clinic. He's a cardiologist. I think I have a chest wall contusion. Can Dr. Joe bill me as a new patient? Yes, because what I hear? New problem. Very good. Okay, because it's his examination is going to be very different as a cardiologist than musculoskeletal from a chiropractor. Okay? But look at the prices, and you're going to see why treatment providers have the incentive to upcode, right? Can you see those prices? Now, look at the 99205. That's moderate high for problem. History is comprehensive, examination comprehensive, decision-making complexity is high, and so you can see what the prices are. Now, the component that makes the highest weight in all of these is the decision-making complexity. Where I'm seeing a lot of abuse in California, especially right now, is when someone goes in for a consult, and their billing is a 99245. And I would love to get into a debate with Mr. Plaintiff Attorney, but I can show a jury that if you take a doctor's visit and they read the doctor's visit, because I can do a cut and paste of the doctor's visit, and they've billed a 99245, and I can explain to a jury, yes, this doctor did a very complete history. Yes, he did do a very complete examination. But the decision-making complexity was very simple and very elementary. He prescribed a route of physical therapy, Advil, come see me in 6 weeks if the physical therapy doesn't help you. Juries can understand that. So I downcoded that 99245 down to a 99243. And I'm not making up the rules. This is black and white with the American Medical Association. 99203, all of this must be again, covered, and a good example of a 99203 is an independent medical exam. Okay? 99205, this is the one that if you get nothing else from today, there's probably a couple other things, but if you get nothing else from today, look at that third bullet. In order to bill a 99205, clinical decision making must be at a high level. CPT, who puts out CPT? AMA, American Medical Association, puts out CPT, defines this as likely to suffer death or serious complications. Now, as a former trauma nurse, that means you're going to croak in the next 30 minutes. Either your heart's going to stop in the next 30 minutes, you're going to quit breathing, or you're going to bleed out. And we're going to get into trauma team activation. You've got a hospital right here in Sacramento that has very inappropriate use of the trauma team activation. We'll go over that. But likely to suffer death or serious complications. You know what, they always tell you about, I'm sure attorneys, you've got your own, what you don't tell the public. Well, let me tell you what trauma nurses talk about when a patient comes in. If a patient's a true trauma patient, we like to make sure that before they leave the ER, they have a tube in every orifice. And we like to create orifices where you don't have them. So anyway, I just want you to know that. All of you have heard of a side note, OOC, like out of control, like pain out of control, or let's say another one's ROM, ROM is what? Range of motion. AROM is active range of motion. And AROM in OB means artificial rupture membranes, which is snag the bag when the mom's in labor. And then one that you probably won't hear in any of your Lamaze classes is FLK. How many of you know what FLK is? Funny looking kid. Anyway. This is the one, the consultation code that I was talking to you about, 99245. This criteria has to be met or it is not appropriate for it to be billed. And so I'm seeing this over and over again. And I encourage you guys to call me. I mean, Tom's called me, Sunny calls me. Just call and ask questions. Okay, is time a key component? It can be under certain circumstances. Sometimes you'll have a doctor that will say, well, I spent 60 minutes with the patient. Well, if you talked about who won the Giants game, well, that's not medical care. Sorry, guys, but it's not medical care. So it not only has to be documented, but also there has to be clinical justification. I want you to know, and I don't know about legalese, but in medicine, it doesn't matter if you are a nurse, a neurosurgeon, a physical therapist, a massage therapist. We're all taught in medicine, if it's not documented, it's not done. If it's not documented, it's not done. Okay, here's E&M services. I'm going to go over this. Upcoding. Okay, so we talked about upcoding. Here's some elements of decision making. And again, you know, if I go to trial, I can talk about type of decision making as far as straightforward, low complexity, moderate complexity, high complexity. And then we can look at minimal. And if you look at the second bullet, low, look at the third bullet down, acute uncomplicated illness or injury, cystitis, allergic rhinitis, or simple sprain. Now, a sprained strain hurts. I mean, it can interfere with your activities of daily living. It's not fun, but it's not life-threatening. You know, go to the next one, high, and you can look at some of these things, and you can see that, you know, if someone's, you know, needing an amputation, or they're having some kind of catastrophic event, MI, myocardial infection, they're going to need some of these things that are life-threatening. I mean, all of you guys are really smart. I think that I say we put too much mystery around medicine, and I really think that we need more transparency. How many of you are aware here in California that your Department of Insurance puts out a website that has what each hospital charges for every single item? Ooh, anyone? Tom does. Yeah. I will send that to you. That's something that you can do. I mean, people will say, what can I get out of this? Is it so complex? I'm going to give you some tools that you're going to be able to establish the credibility of a bill yourself after today by looking at it. Because I know Tom has found where there's hospitals that have different fee schedules, whether or not it's a car accident or it's health or workers' comp. I mean, I think it's really interesting. I've done on-site nurse consulting right here at Liberty Mutual here in Sacramento. And I love it because they have the work comp side and the personal injury side. And it's great because you can go and on the personal injury side, you'll see a problem provider. But you'll go over the work comp side and they're billing perfectly. And it's like, wait a second, this isn't jiving. So I love to call the treatment provider and say, I need to talk to your coder. Oh, we have two coders, one for workers' comp and one for personal injury. And it's like, let's do a referral to SAU. So that's not, so, and the way Tom has established credibility of a bill is this is something that the hospital, I'm not saying it's reasonable and customary, but this is what the hospital puts out that they are going to charge for each of these line items. So I always encourage the first thing for an attorney to do or have your paralegal is to go to this website and then check to see if this is appropriate. Because if it's not, then right there you can have credibility of the bill challenged. Okay, unbundling. Okay, this is one that really is, if someone can show me a hospital here in California that does not unbundle their labs, I want to see it, okay? Unbundling. Let's say that I go to, let's say that Dr. Beth is my primary physician. So she is a medical doctor. She orders a complete blood count. So I go over here to Joe, and now Joe is a phlebotomist, and he's going to draw my blood. So he draws my blood, and then Tom owns the lab, and he goes, well, the doctor ordered a chem profile, but I'm just going to unbundle it. So I'm going to bill each of these components separately. So instead of an 80048, which is a metabolic panel, which is $46 in Fresno, it would be coded as separate tests. And so the total cost instead for calcium, creatinine, and glucose, each of those would be $167. And again, I've had people say, well, that's not very much money. I can't deal with this. Well, I want you to know that Dr. Tom, he's a good, smart business owner. Joe is not challenged. If they're doing staffing, we know that Joe, as a phlebotomist, can do 8 blood draws per hour. So take 8 blood draws times 8 hours for one phlebotomist times 40 hours per week, and it adds up. But look at your hospital bills, because you're going to see where these are always unbundled. Okay, really quickly, these are some other ones that I see as unbundled, and the one that I see that's unbundled a lot here in California is 80100, drug screen, multiple drug classes. And again, if someone's acting loopy and they go into the emergency room, it's perfectly appropriate to have a drug screen drawn. However, it should be an 80100 drug screen, not your amphetamines, barbiturates, cocaine, each of them separately. No, And what I'm seeing this done, we're having a lot of issues right now with patients being on like OxyContin and going in for their urinalysis. And I'm seeing 2 labs that, and if you want to talk to me afterwards, that are unbundling. So it should be a $60 urinalysis is coming out at $1,100. Okay, unbundled report code. There's some treatment providers, let's say that Dr. Joe is getting smart. So now he's saying, okay, I'm in charge of I own this doctor's clinic, or 49% or whatever. But however, there's too many auditors around, so I think that I'm just going to, instead of billing a high evaluation management code, I'm going to have my coders bill a lower evaluation management code, but we're going to add this report code, 99080, and just add $100 on every time we do an E&M code. Well, I just tell you, that's unbundling. I don't make up the rules. The American Medical Association makes up the rules. And report is not appropriate. So if you see the CPT code, disallow it. And unless you have specifically asked a treatment provider for a report. Okay, duplicate charges, this happens frequently. Provider will send a bill every week. And believe it or not, there's still some companies out there that are not doing bill review on a regular basis, which is really sad. Radiology and imaging, the last audit that I did is I found that you are paying for your radiology codes twice. And people say, well, how am I doing that? It's because they are accidentally on purpose leaving off the modifier. So I'm trying to be nice, okay? And jurors listen to me. Even if I'm the last juror at the end of the day on Friday, jurors listen to me. And if one goes to sleep, I'll look them in the eye. Anyway, 72050. Let's say that Dr. Beth, after this horrific accident, is ordering a neck x-ray. So 72050 and is a neck x-ray, and it has a technical component and a professional component. All of you are aware of that. I mean, you've all had an x-ray where they say, hold your breath or whatever, and then you have a radiologist that reads it. What will happen frequently is where both providers leave off the modifier. So you have both, I'm going to say like UC Davis billing 72050, as well as the radiologist, UC Davis billing group, radiological group, billing 72050 without the modifier, and you're paying for that x-ray twice. Do you see that? Happens all the time. I had a deposition right here in Sacramento. I can't remember who was opposing counsel or who was defense counsel, but opposing counsel was a female attorney that she was sure that she was going to be the first one that got me disqualified. And she was just full of it. after I explained how the numbers had came up, where I came to, they stipulated to my numbers after my deposition. eSTEM. This is one of the things that's talked about in how to bill $6,000 to $10,000 more per auto accident or work comp accident. And 97014 is unattended electrical stem. 97032 is attended electrical stem. So let's say that, again, Dr. Joe being a business owner, he's really on top of it. So he's got patients out in a room, and let's say Dr. Joe now, you're a physiatrist, and you've got 6 patients out there, and they are all on electrical stem. They should be on unattended electrical stem, which is 97014, but he's billing it, so the usual and customary price is $30.94, but he's billing attended electrical stem, which you can bill a unit every 15 minutes at $33. Okay, eSTEM attended requires direct face-to-face contact, not in and out, but direct face-to-face contact, as well as electrical stem. And it needs to be clinical justification. And the 2 components that I've ever seen for this in my 15 years of doing this is, one was a 92-year-old woman that they were worried about her being fragile and falling off the bed, so I'm fine with that. Another one was a 20-something-year-old guy that had Down syndrome that the time before he gone zip and went whoop, tried to levitate, and so that time, I think they needed to have attended electrical stem. Those are the 2 cases I've seen. So 97032 is a red flag. Neuromuscular reeducation. How many times do you guys see this code? 97112. All the time. Geico did a national study on where this code is abused the most with soft tissue injuries. Guess what? Guess what state was the winner? California. Yay, California. Anyway, guess why Florida doesn't bill this?
They don't allow it?
The insurers aren't paying for it. And so if the insurers aren't paying for it, then the treatment providers don't bill it. This is not a type of massage. It's used primarily to treat individuals with a neurological deficit caused by a stroke or traumatic nerve injuries. And I will be sending you out some information that is a couple articles on neuromuscular reeducation, as well as a stance by the American Medical Association. And this is just something that I want you to just really watch out for, and tell your paralegals when they're going through the bills. And 97112 is, let's say that grandma has had a stroke. So Dr. Joe, you're multifaceted. So now he's a physical therapist. So Dr. Joe will have physical therapist Joe will have grandma put her arm through a screen, and there's a screen here, and try to identify this coin. Is it a nickel or a dime or a quarter? You're trying to get the neurotransmitters crossing the synapses. It's very specific. Or maybe one of our Iraq victims has lost a limb, and they're learning to walk with a prosthesis. You're trying to get the neurotransmitters crossing the synapses. It's very, very, very specific. It's not just coming in and doing a nice massage. Why do you think they do it? High reimbursement value. Okay, billing for services not rendered. I'm not going to spend a lot of time on this because I know that I want to get to some of the fun stuff, and I know I've got a really limited amount of time, and I can only talk so fast. But activation of the trauma team, I think UC Davis here in Portland, or UC Davis here in Sacramento actually started this. And now I see it all over the West Coast. I see it down in Texas. I just did a major project for Allstate Defense, 50 cases at one hospital where it was not appropriate. And there's very specific criteria that has to be met when a trauma team activation occurs. And I'll be sending some of that out to you. But I want you to know that it has to be documented. A doctor can't just say, oh, let's bill this patient as a trauma patient. Think of when you guys watch ER, Grey's Anatomy, whatever show you watch. When someone comes in, I like to say that we descended upon this poor protoplasm. That's what we used to say. And so if you don't have, like 2 nurses, a respiratory therapist, a doctor, a trauma surgeon, people blowing, IV therapists, blood draws, something's going on. You guys know, if they're discharged from the hospital 3 hours later, forget it. There's 3 different guidelines for activation of the trauma team. And again, this is put out by the American Trauma Society. It's a group of 10 trauma surgeons that get together every single year. Mechanism of injury, if there's a fall greater than 2 stories, I think one that I see a lot is where maybe there's been a fatality in the front seat and the back seat passenger, it seems to be okay. But if there's a fatality, activation of the trauma team is appropriate because you don't know what else might be going on. Physiological criteria includes Glasgow Coma Scale and blood pressure. How many of you know what GCS is? Glasgow Coma Scale, anyone? I will be sending this to you. This is something that I want you to all start looking at when you're looking at your medical records. All ambulances will do GCS, Glasgow Coma Scale, as well as all ERs. If their Glasgow Coma Scale is 14 or 15, they don't need the trauma team. Anatomic criteria, I think any of you can look at this and you're not going to question any of that, right? Okay, and this is who activates the trauma team. Okay, there's also proper coding for the trauma team. And again, this is put out by the American Trauma Society. It must be billed with this HCPCS codes, and then there must also be a bill for 99291, 30 minutes or more of critical care. And when I was at doing this big fraud project down in Texas, I said, why aren't they billing the 99291? And what the defense attorney said for Allstate, he said the reason they're not doing that is because they don't want to get in trouble for billing for services not rendered. They're billing, they're just accidentally, they'll say it was just an accidental on purpose coding error. Yes?
Does that have to be done only at a trauma center?
Anytime if a trauma team is billed, they have.
But if you're in the hospital in King City, which is not a trauma center, they're not supposed to bill for it.
They can, there's some hospitals like Kern County doesn't actually, like down in Fresno, no, Bakersfield, does not have a trauma center, but they still will bill a trauma team activation, but it still has to be billed this way. I'm not familiar with King City, but.
Well, I mean, they have two doctors in Georgia.
Okay. Hopefully the ambulance wouldn't take them there. In Portland, we used to have an ambulance service called Care Ambulance, and when I was Life Flight, we used to say, take a dare with care. Anyway, here's a surgery that never happens. I think that got talked about earlier. Okay, Howell versus Hamilton. This is creating a lot of issues because I think more and more of the patients are having their care done on a lien basis. Okay, we've been through this, the gamut of case law, and I'm just going to keep going. And I am not a nurse, not an attorney. I'm not sure what will work in your case, but I know that theoretically we're back to amounts paid, and there's complications to some of these where there might not be a paid amount on the lien basis, or Kaiser treatment with no bills, or VA cases with no bill. And if you have those, then what I encourage you to do is give me a call and we can do a mock billing invoice. And what I do is look at the medical records, apply CPT codes, and then run it through usual and customary. And I think, was that your case or Sonny's case that had 3 inches of Kaiser treatment? It was like, oh. Okay, medical summary statement. This is something that I do a lot, and this is if you do have EOBs, explanation benefits, where I list each provider, the amount billed, amount written off, amount paid, and amounts due. Mock billing invoice is what I was just talking about, used to establish a reasonable amount of bills if you don't have, if you've got Kaiser or VA, or you're trying to get a bill from healthcare recoveries. I have never seen a bill from healthcare recoveries that is accurate. And just as an FYI, I do both sides. The numbers are the numbers. Pardon? Oh, that someone said. Okay. Billing and coding reviews are sometimes very appropriate, especially on the lien basis, and then take it and apply the recommendations to the bills for usual and customary. I'm going to go over some of this. Here's an example of a medical summary statement, but you guys can look through these on your own or call me for any questions. I try to make my reports very simple so that I can explain them to a jury. I mean, that's my basic thing, is taking the mystery out of medicine. Here's some useful tools. This is something that, look at the third one down, Red Book 2010. This is something that I think every office should have. I'm seeing more and more where treatment providers are dispensing their own pharmaceuticals and jacking the price through the roof. And there is a reasonable and customary price for pharmacy. So I encourage every office should purchase the Red Book. And then the CPT Assistant Archives, and I think free is good. So here's some medical fees. Red Book is a whole $139 on Amazon. Being a business owner, I like cheap is good. Free is really good. Here's some IC9 codes and ICD-10 codes. Here's some medical billing examples. Okay, another thing that I'm seeing a lot, I don't think I've seen it here in Northern California, but in Southern California, I have seen it a lot where hardware is being billed to the patient. Anytime you see where hardware, like something's put in the ankle or something's put in the back, if it's billed to the patient, major red flag. This is one where the prices for the hardware were about 10 times what was on the implant provider's website. So if you get hardware, major red flag. This one that was like $37,000, it actually turned out that when it went to jury trial and they did a deposition of the person that created this, they'd put the decimal point in the wrong place. It should have been 3,760. Accidental on purpose. Okay, innocent looking bill. However, for this provider, they were billing advanced life support, and it should have been basic life support. And you know, it doesn't look like that much, but that bill should have been $300 rather than $600. And those add up. Okay, paying for radiology over and over and over again. This is one where it's a bill that you got from the hospital. There's no modifier. And if the doctor orders the tests but does not read them, like put some kind of note that he read a chest x-ray, he cannot bill for it. If he does read it and puts a note, chest x-ray clean, fine. So this one, there was no bill, and the doctor also had not read these. And then you have the bill from the imaging company. There was no modifier. And this is the same case. Got the bill from the radiologist. Hey, they did the -26. Yee-hoo. And then you've got the bill from the emergency room physician, correct modifier. Yay-hoo. However, there was no chart notes that he had looked at any of these. So the carrier paid for this one 3.5 times. Okay, let's go over fluoroscopic guidance. Hey, if you guys see 77003 included in any of your epidural steroid injections, they are unbundling it. And I see this all the time. I mean, it's only like $250. I've seen it as high as $600, but you can see it's the last one, 77003, the last bill, and it's unbundled all the time. And anytime you're looking at a bill that has any kind of epidural steroid injection, take out slide 159 and look at if fluoroscopy guidance is included in all of those procedures. And I've not seen one personal injury case that they're billing it correctly in California. However, on the work comp side, they are. Anyway, one expensive exam. The chart notes only supported 99242, and they billed a 99245. And then there was no documentation of the prolonged service. And then look at the 99080. They billed 5 units of it because the doctor said it took him 5 hours. And so I downcoded 99245 to a 99242, and an $1,100 exam was down to about $250. And when you show a jury the chart note of what occurred and that it was a checkbox, they get that. Okay, this is one, if you see team conference bill, this is a red flag and soft tissue injuries, and I can go over that later. Okay, bilateral injections. I know that I'm seeing a lot of bilateral epidural steroid injections here in California, especially Northern California, and when it's done in bilateral the second one is supposed to be billed not only with a -50, which this one did correctly. Do you see where they've got the -50 on LT50 on those two? And also, that price should be half price. So they did the correct thing by billing the LT50, but they did not discount the price in half. Accidentally on purpose, of course. Okay, this is one that should be a metabolic panel at a fraction of the cost. This is one where it was actually a jury trial that I did up in Chico. This gal had a bad injury, a loss in an eye, all sorts of good stuff, had a lot of occupational therapy. You can see all the occupational therapy billed on 218, all the occupational therapy billed on 220. Look at the chart notes, and you can see SOAP for both 218 and 220, you've got 60 minutes for 218 under the O, 60 minutes under 220 for the O. Then you go on to duplicate charges. You've actually got a total of 120 minutes billed each day, and it was only 60 minutes actually done. Make sense? Okay, this is one, and that was really interesting. It was on a jury trial that I just did down in San Bernardino, and it was, look at the treatment provider, and you've got one tax ID number and a specialty clinic, and the billed amount, and then you've got a different tax ID number, but the same patient, same date, same codes, same amount. This was duplication, and you know what, how much, $3,000 or something. I mean, just duplicate billing. And you show this to a provider, you show this to a jury with one chart note, they get it. Okay, how many issues in one bill? This one was 99245, it was upcoded, and then the 99080, the report code was unbundled, and then the duplicate charge that the cervical flexion is included in the cervical AP. Okay, don't like the first bill. This was a doctor that, I think it was up here in Northern California, where he turned out that he said that he should have been an assistant surgeon, he should have been a co-surgeon rather than assistant surgeon. So you look at the first date of the bill, and he's billed like $16,000, and you can see all the procedures are the same. And then you go to the next one, the next bill, a year and a half later, almost 2 years later, same treatment, same dates of service, almost twice the price, because he said he should have been a co-surgeon. Okay, and you can see here where you show the jury the op report, surgeon, assistant surgeon. It's really clear, right, guys? Okay, this is one where, look at your OR time. It's huge. It's really overbilled. This one was 3 hours and 30 minutes of OR time, and the actual OR time was only 2 hours and 34 minutes. Look at the pricing for your OR time. $18,000 for, that's huge. Okay, Surgitech, if you see this, it's a red flag. This implant number did not match the implant log. One of the numbers was a screw, not a pin. The other one was a nut, not a tip. Just one thing is make sure if you have anything that's implanted into the body, get a copy of that implant tracking log. That's really, really important. That's law in the entire United States. Anytime you put something in the body, you have to have that implant tracking log, and that's a good way to check against the bill. Suspect bill, it was billed to the patient. And to me, none of this should be controversial. And questions for you is, I think that we've allowed too much of this to go on for too long, where it's almost considered common stance and accepted as normal. And it's black and white, guys. And it's like being pregnant. You're either pregnant or you're not pregnant. It's just like, I don't think there's soft fraud and hard fraud. You're either pregnant or you're not. And we need to do something about it, all of us together. Thank you very much. Yeah.
Assuming that the bills have been paid by a health insurance company like Blue Cross or Health Net or something like that, how good are they at looking at the codes and paying a proper amount?
They do fair. They do, I'd say, they do about probably 50 to 60% accuracy, but providers also bill better to a health carrier than they do to the auto carrier or personal lines carrier.
Okay, so the bills, if you have an explanation or benefits from Blue Cross, they might not require as much scrutiny as direct bills from UC Davis or something like that.
Correct.
Okay.
Anybody else?
Thank you for your emails. Words that come out.
Let me just tell you, plaintiffs' lawyers hate this stuff. And we got a little glimpse of that earlier. And what that means is if you have 6 digits or 7 digits of medical bills, the kind of stipulation that the plaintiff's lawyer is looking for can be had by a person with this kind of expertise, this kind of detail, this kind of knowledge, who lays it all out in front of them, and they will stipulate to the reality. And if they don't, they will get burned at trial. So you get a double bang for your buck with this kind of expertise when the case justifies it.
And another thing that comes out is, do you know any medical providers, doctors that know this information, what the codes are, how much you can charge?
No.
So that way, it's hard to have the doctor go up there and say, oh, you need a
back surgery and it's going to cost $140,000, they're not qualified to say that because they don't send out the bills. They don't know these codes. So you need to push the plaintiff's attorneys to their burden of proof or have the medical doctor, it's called a 402 or 405 hearing, where they have to show that they actually have the expertise and knowledge to say how much it's going to cost to do a certain surgery. So we should push the plaintiffs to their appropriate burden of proof.
And I think doing a cost projection on when there is a future surgery, if it doesn't make sense to you guys have a good guts. You guys know what you're doing. I mean, even though you might not have RN after your name, you guys are really smart. And if it doesn't feel right, just give me a quick call because it really, something is not right. And I had a jury trial, I think here in the Bay Area, on cost projection. And plaintiff attorney was saying, and how are you, a nurse Rockholt, qualified to say that this surgery and this esteemed surgeon isn't going to be $250,000? And I said, this is how I get it. I do the pre-op lab work, anesthesia, surgeon, assistant surgeon, facility, post-op physical therapy. And I outline it out. And if you guys want an example of a cost projection, I'll send it to you because it's very detailed and it's black and white. Again, it's the numbers. And there are some good plaintiff attorneys out there. I mean, when I had my ski accident, I had a good plaintiff attorney. I didn't tell you that the hospital billed me twice for the same night. So anyway.